So let's start. So we start with ECG. See, when we talk about ECG, this is electro, then there is cardio and gram. Cardio is heart. Gram or the graphy, that is the representation on paper. So it is as good as writing. So when we are writing electronically about the heart situation, that is what is called as the ECG or the electrocardiogram. At times it is also known as EKG, it is also known as EKG. It's one and the same thing. There is one more thing which is called as the EEG. When we'll be learning the neuro, at that point we'll learn about it. Is the voice okay? Because over here the meter is showing fine. Can everyone hear properly? Manthan, try to, okay, it is good for everyone. So Manthan, try to relog. We'll wait for you. Just relog. At times it happens. It's even if the bandwidth is okay, but sometimes there is some glitch, so it happens. So what I was talking about was EEG, electroencephalogram, right, for the brain. Now that thing is pretty complex because it is comprising of number of waves, but very interesting. Right? Okay. So that's a topic for ECG, and we said that this is part one. Yes, today we'll be covering the complete foundation. So much so that we'll be sitting on that point by the end of today's session. It is same. Let's say K is cardio, the way it is written in Greek language. So one and the same thing. So what I was talking about is that today we'll move on till that point when all the basics are clear, and straight away from next time onwards, we'll start watching the ECGs one after the other. So today is that foundation. From exam perspective, don't know the importance. To be honest, very less importance. But in order to know this thing, it will help you a lot when you'll be reaching, when you'll see any of the ECG. It is my responsibility so that by the end of today's session, if I say that, okay, we are now talking about lead number 1, so immediately your face should turn, yes, we are watching the heart from the side. If I say lead number 2 and 3, so then immediately within split second, it should come in your mind, yes, we are watching from below, correct? Manthan, if the voice is not clear, so then it is, because for everyone, it is absolutely fine. The complaint is only from your side. Only one, and over here I can watch the bandwidth is absolutely fine. So see what you can really do. Normally when you try to relog, it becomes quite okay. All right, so let's start with the fundamentals. We'll be moving in these directions. This will be our action plan for today. So this would be our action plan. First, we'll be going for the circuit, that what exactly would be the circuit. Though we have already talked about it as an, but still we'll just have a look at it. Second, from the circuit, we'll be moving on to the action potential. Because over here, we'll be dealing with two things. One tissue, which is not moving, second tissue, which is always moving. Right? So one is the electronic component. It is like one is the electronic component, and second one is like a motor, something which is moving. Right? So we'll see the difference between both of them. In other words, we'll be watching for the pacemakers. We'll be watching for the pacemakers, and we'll be watching for the cardiac muscles. And then we'll go all the way to the 12 leads. Right? Which are the leads? and then we'll see the science behind it. The science behind it, it means once we have understood this, it will give you that perspective that why it happens like we are watching this specific lead and just watching the ECG and then you straight away say that this is a septal infarct, right? Just by watching the ECG. So this is what is in our today's platter. So here is the first thing first. That's the SA node. Things which you already know will be going a bit fast, right? So here we are dealing with pacemakers. Right? Pacemakers. Pacemaker. Pace means speed. Someone who is setting up the speed. So we start our journey with SA node, sinoatrial node. Now see, last time when we were talking about SA node, we said that there is one branch which will be going to the left atrium and left atrium will start working on it. Exactly the same way there is one branch which is going for the right atrium. So here is the right atrium and here is the left atrium. And then there is a branch which is going all the way, and that branch which is called as the Buckman's bundle. Right? So it is the Buckman's bundle. So here is the branch which is going all the way to the left atrium and supplying it. Right? So that is what is called as the Buckman's bundle. Next, here is, so this is one. Second one is the AV node, atrioventricular. When we divide our heart into two parts, the heart part which is above and the part which is below. So over here this one and over here this one. So this is like right atrium, left atrium, and this one would be the right ventricle and the left ventricle. So above and below. So here we'll just write, it would be sufficient that atrioventricular node is the only window. Right now, when I say only window, you understand it instantly that it is the only window between upper heart and the lower heart. Clear? In case if it is not clear, anything which is doubtful, just let me know. Otherwise, I'll take it for granted that some things which we have discussed so many times, you know it properly. But still, if there is any doubt, please let me know instantly. Right? Today's session is like it would be very difficult to go back. Right? It won't be possible. Because as we'll be mounting our concepts one after another. So please, as soon as there is any doubt, tell immediately. So SA node to AV node, that's why AV node is important, because it is the only window between upper heart and lower heart. One, and the second part, and that is it injects delay. And you know the delay is so that the ventricles, they get enough time to fill the things properly, fill them with blood properly. So that was atrioventricular node. The third one which is coming up is the bundle of His, or the His bundle. Right? Ideally, it should be written like HIS, His bundle of His. So that is the bundle of His. That bundle of His, it goes down and then it starts dividing. There is a right bundle and the left bundle. Right? Here is the right bundle, this one, and then there is a left bundle. And in left also, there are the left posterior bundle, which will be supplying all the way. Because who is situated sideways? It is the left ventricle. Because front to front, this front portion, that is the right ventricle. Left ventricle is on the lateral side. So that's why these left posterior bundle, right, they will be going all the way to supply to the ventricular. That is the left ventricular musculature. Right? So all of them, they are now called as the Purkinje fibers. These are the fibers which will be going deep into the muscles. Right? So these are the branches of bundle of His. That's right, bundle of His. So bundle of His is over here. Then it divides into right branch and the left branch. And that is the thing when we'll be talking about left bundle branch block and the right bundle branch block. There would be a situation when we'll be telling that it is LBBB. Left bundle branch block or the right bundle branch block, right? But right now, not confusing. Things are easy. When, let's say, when the circuit breaks over here, so that means both the bundles will be blocked. What obvious. When the circuit breaks over here, so that means it is only the right bundle which is blocked. Right? But so it is that simple. So right now, we understand to this point, right? Sinoatrial node, AV node, and the bundle of His, and then the right bundle and the left bundle, and finally the Purkinje fibers. Right. So here it is, non-superimposed view. So over here, rest of the musculature has been removed, and we see SA node, atrioventricular node, right? All the others. Here, just remember, this is the Buckman's bundle, right? Buckman's bundle, and this was one of the question also. So let's remember Buckman's bundle, which is supplying the left atrium. Right? Okay. Next is, so this is the circuit on which we shall be working. Right? This will be the circuit. Next, a very important concept, and that concept is, here is the SA node. Now let's go to micromolecular level. This is the SA node which is sending impulse to, this is the cardiac muscle, right? This is the cardiac muscle. So it is sending the impulse to these cardiac muscles that contract. So SA node is like an electronic system. There is no movement into this tissue. Right? This is a non-contractile tissue. This is purely electronic. Generates impulse only. Right? Impulse generation. Generation only in capitals. While all these are contractile tissue. Right? These are the contractile tissue. These are the contractile cardiac tissue. Contractile cardiac tissue. So they will contract. Speciality of this is that normally when we talk about any of the skeleton, every skeletal muscle is a separate structure, right? Not in case of heart. In case of heart, they all are connected. They are connected by a window, and that window is called as the gap junction. This gap junction is the speciality of the cardiac tissues. Okay? So it is the specialty of cardiac tissues. So first, let's see the action potential. What really happens in case of SA node? Now, when we talk about SA node, then SA node, AV node, bundle of Hayes, Purkinje fibers, same things would occur. But the difference between is that SA node is a high pace system. AV node will be still slower, others will be still slower. Right? So it will be slower and slower and slower. So first, we talk about the SA node. Same principle will be applied to all the other pacemakers. This is the concept which is called as the automaticity. Automaticity. Automaticity means without any impulse, without any motivation, without anything, it keeps on generating the signals. Right? So this is automatic signal generation or the impulse generation. You won't find such characteristics into other tissues. They always need some stimulus. Over here, for heart, no stimulus is needed. Right? It generates everything by itself. So what is that which is leading to this part? Let's see that. If we try to draw the graph, we'll draw the graph simultaneously for the cardiac tissue as well as the pacemaker tissue. So this is our pacemaker. In this, the spike would be like this, and this. We'll be going into the details, but it would be like this. Impulse goes, right? Impulse relieved and then dropped. Impulse goes and it gets dropped. Automaticity means without any impulse, because if you contract the muscle won't be contracting by itself. It requires impulse, right? It requires action potential. So something occurs and then the muscle contracts. Right? Whether it is heat, whether it is pain, whether it is touch, anything, but muscle won't contract by itself. While in case of heart, this particular tissue that is called as the SA node, it has got automaticity. That means without any reason, right, it will keep on sending the pulse. And in response to, these pulse, heart will keep on contracting. Now, ideally, heart should contract like this, but it is contracting like this, right? See the difference. This is how the skeletal muscles contract, one after the other. This is how cardiac muscles contract. It is because in between, there is gap junction. So that's why all of them, they fire at the same time. So it is the gap junction because we want the whole heart should be contracting together. So here it is. This is the pacemaker. So in pacemaker, simply the pulse goes up and then drops, goes up and then drops. And that's it. That's how it really goes. Right? That would not be the case in case of cardiac muscle. Cardiac muscles, it will happen like this. It will go up, then it will be coming slightly down, and then it will form a plateau. It is this during plateau when it is contracting, and then it drops. Then it drops. So this plateau is the crucial thing. This is where the heart rate, the muscle contracts. Muscle contracts. But what's the point? Right? For the pacemaker, so there is no contraction needed, so that's where that phase would be eliminated. So when we see it over here, we see here the first pulse would be like this, and in response to that, everyone will be contracting like this. Right? So this is the characteristic of pacemaker. Let's see how it really functions. We start with the pacemaker. Let's draw some channels. So here it is. Here are our channels. So this is outside and this one is inside. Right? Intracellular extracellular. So over here, outside there is always so much of sodium. Right? Inside it is potassium. Now the first channel which is coming up is, it is called as the funny channel. Its name is like funny channel. Right? Just a minute. Yeah, so these are called as the funny channels. What funny channels do? Simply, small amount of sodium will keep on coming in. Right? These are the funny channels. So this is where the sodium is coming in. Right? As such, the concentration is high outside, so it will simply keep on coming. So this is the sodium. Now, this sodium, as it comes, so it will lead to generation of what? A generation of positivity, right? So because of this sodium, right? So that would be the spike. And then at one point, as it reaches, it drops, right? Because over here, sodium channels, they stop, and the potassium channels, voltage gated potassium channels, they will open, and the potassium will start leaking outside. So potassium will go out, correct? Potassium will go out, and it drops, right? As the potassium goes out, and it drops. We are measuring all the voltages with this perspective inside. So as the sodium comes, so the voltage keeps on increasing. So that's how the pulse is generated. So for pacemaker, things are pretty simple, pretty easy. Right? But in this, we need to add something extra. And that is, what about this middle part? Because see, if the sodium is entering slowly, so then the graph would have been like this now. And then the potassium opens and it drops. Are you getting it? It won't be like this. So when we say this means it is fast acting. Right? That's where this middle one comes. These are fast channels. These are fast channels. So these fast channels, they will trigger lots of calcium. They will trigger lots of calcium. So when this calcium pushes in, now we can see what really happens over here. So the whole thing goes something like this. So this phase, this is the phase of funny channel. This is called as the phase 4. Phase 4. At minus 40 millivolt, it is the rapid calcium, fast calcium, they come into picture. So when these fast channels, they come into picture, this is voltage gated, right? So this is VG, voltage gated. So there would be the spike because this is fast and large amount of calcium as it is entering. So here it has to spike. This is called as the phase of depolarization. Depolarization, also called as phase 0. Phase 0. Then from this point onwards, things are easy. At this point, sodium channels, they stop, calcium channels, they stop, and the potassium channels, they open. And then there is rapid descent of the voltage. Because these potassiums, they will start going out, that channel opens, right? And it comes back to the resting membrane potential. So this is the whole journey. This, as it goes, comes down, it is called as the repolarization. Right? It is called as the repolarization. And that phase is called as number 3. I mean, over here it was phase 0, right? From phase 0 straight away to phase 3. Yes, from 0 straight away to phase 3. And then this baseline, when it comes, it is called as the phase 4. So where are phase 1 and 2? Right? Hang on for a moment. When we discuss the muscle, or in simple words, this is 1, this is 2. That is 1 and 2. That is the phase when there will be the contraction. Because over here, that's where the contraction occurs. In case of pacemaker, there is no contraction. So that's why there is nothing like phase 1 and phase 2. Okay. Now, when it comes to cardiac tissue, for cardiac tissue, let's say this is our acid. That is also having a gap junction. So that calcium, that sodium, which has entered, right? It will be entering. These are the gap junction. So it will be entering into sodium and calcium. They enter. Similarly, over here also they enter. So for them, this is a stimulus. When this is stimulus, this calcium, right? When this calcium comes over here. So in case of this, here is the sodium. This is fast sodium and calcium. Fast. At this point, at the peak, sodium stops. Sodium channel stops. Calcium is still there. But because the sodium has stopped, so that's why it will come down slightly. And then at this junction, the potassium channel is open. Calcium is already open. So thus, whatever the amount of sodium which is, whatever the amount of calcium which is coming in, right, at plateau, the same amount of potassium is going out. So this is the calcium, this is the potassium. So they both are balancing each other. Right? This is what is happening at plateau. This is what will be happening at plateau. So at plateau, we'll see that both of them, they have been balanced. And that's the phase in which we are very much interested. It is this phase. It is this phase. Then at the end of the plateau, again the same thing, and the potassium remains open, calciums they close, and it drops all the way down. These two phase 1 and 2. 2 though it is called as plateau. Easy. 1 is called as the initial repolarization. Initial repolarization. One is initial repol or repolarization. Polarization. Okay. So thus we have the initial sodium phase. Then there is a depolarization one, which is the phase 0. Then there is initial repolarization phase 1. And then there is a plateau, which is phase 2. And then there is phase 3, which is a regular repolarization. So that's how this entire game keeps on working. It is this funny channel which is allowing that, yes, let's only the sodiums they keep on coming. When the sodiums they are coming, they raise it to threshold level. And it is that threshold level that is when these fast channels are triggered, because these are voltage gated. And then the whole rush, right? Whole rush. And then the game of this plateau. One question which can occur is that till this point, everything fine, right? But what about the contraction? How the contraction is occurring? The amount of calcium which is getting injected, that amount of calcium is very less. It is actually very, very less. That much calcium is of practically no use that it can really contract. But in case of cell, there is a kitchen which is called as the endoplasmic reticulum. Endoplasmic reticulum. So it is inside. This endoplasmic reticulum, it is a storehouse of calcium. Right? It is a store of calcium. But because it is store of calcium, because it is stored into the stores, that's why we cannot eat it, we cannot use it. So the calcium which has come from outside, the calcium which has come from this gap junction, the calcium which has come during this action potential, that small amount of calcium as it comes in, it actually triggers endoplasmic reticulum. And in this process, small amount of calcium, it is like a key, right? It is like a key. It unlocks, and this entire store, it releases large amount of calcium. It releases large amount of calcium. So, right? So that's why this is called as the calcium induced calcium release. Small amount of calcium is inducing the release of large amount of calcium by opening the gates of endoplasmic reticulum. So that's how the contraction really starts. Any query till this point? Where does that large amount of calcium goes? This large amount of calcium, it is utilized for muscle contraction. This is used for actin myosin mechanism. Because if the calcium is not there, then muscles won't contract. So these are the calciums which are used for the muscle contraction. So that's where they are used. Then once again, when the muscles relax, again the endoplasmic reticulum, it will store that calcium. Second graph is for cardiac muscle. Yes, second graph is for cardiac muscle. I'll write it down. Obviously, then and then there can be contraction. So muscle contraction, cardiac. That one is written, this pacemaker. Right. So just another way, That's a one is SA node, two is AV node, and then the bundle of his and Purkinje fibers. Right. Here is a complete cardiac cycle, full complete cardiac cycle. Now here we just utilize this space for one concept, and that concept is all other questions later. So here is our sensor. Right? Here is our sensor. So this sensor is what? This sensor is just understanding the pulse which is coming, current if it is coming towards it. Right? So here it is coming towards it. So then this sensor would record, yes, right. It was like a flat line, and now the pulse has come, current is coming, electrons are coming, so it is like this plus. And then this current goes. So then it will say, okay, it is going, then it will be down. So here is, this is the 1, this is the 2, when the current is coming towards the sensor or towards the lead or towards the electrode, so it is up, and when the current is leaving, going away, then it is called as the 2. Right, very easy. So over here, this is plus, and over here, this is minus. This is the simplest explanation. This is how it really goes. So now that would make sense, no? Okay, if this is a big area like this, and in a normal heart, as the pulse goes, here we have put the electrode. Our electrode is here. So when the current is coming and when the current is going, so it will be forming this way. But what if there is heart attack? So some of the portion is damaged. So in this case, the amount of current which will be coming, which will be perceived by the musculature, because this is the dead area. And this dead tissue doesn't perceive anything. Right? So amount of current cannot be that much, it will be low. So and then so can we say it will be something like this? Because current is passing. Previously, it was this much, the amplitude was this much, now the amplitude has decreased. So whenever there is a dead tissue, it will make a weaker wave. But if it is not fully dead, so then it might lead to some reverberations. That means the current will revolve over there and on and on and on. So might give the appearance like. So that's a basic principle of how the current is really formed. In case of ECG, we use it 12 leads. 12 leads. 6. These 6 are for the chest. So that we just put everything onto those leads, they are onto the chest. But right now we'll be dealing with these. Muscle in order to make the muscle contract, the pacemaker creates the impulse using the funny channel to create the particular graph. Then the cardiac muscle contraction graph is continued throughout the. That's right. Because once the impulse has come, so then the cardiac muscle they contract. Then once again second impulse comes, then once again they contract. So that's why, as the SA node is sending the impulse, cardiac muscles they keep on contracting. When the SA node is not working, now the AV node is working. So AV node is firing the impulse at a slower pace. Right? At a slower pace. So that's why heart is also contracting at a slower pace. It is taking more time. See? So here it is. 6 leads. Out of these 6, we divide it into 3 and 3. 3 leads, they are the limb leads. Limb leads. So over here, the limbs which are used, they are right arm, left arm, the left leg. Using these three parts, we'll be making the complete system. Okay, so that was the thing. Now let's understand this. We have understood just one simple principle, and that is when the current comes towards the lead, that will give a positive reflection. When the current will be going away, it will lead to the negative reflection. When the current is going, it will be minus. So here it is, the first step, start from this point. Right? This is when our entire ECG, right? It will be showing the entire ECG. So here, the impulse generated, and here is our SA node. That is the SA node. SA node has fired the signal. So you can see these things by arrows. Right? So it has fired the signal. It has fired the signal, so that's why this is the P wave. So this is the P wave. So P wave is what P wave is. When the SA node fires, and it is and it fires and sends signals to atria. So that's why it is called as the atrial depolarization. So that is the P wave. Things reach to AV node. At AV node, it is taking time. It is causing the delay. When it is causing the delay, so that is the point when it is waiting, right? That is the point when it is waiting. See, it is waiting from here to here. So that is the point when it is contracting. Then, so let's move further, right? So here, see the blood. Right? The blood is over here. And blood is getting filled. And see, this is the filling phase. From filling phase, now we have reached to this AV node. So now the AV node will contract. So this AV node is sending the impulse all the way down. From AV node, it is coming to bundle of His, because from bundle of His, it will be given to ventricles. So see, as it is passing through that bundle of His, we get this QRS complex. We get this QRS complex, and it is this, because from bundle of His, straight away it will start sending the signals to ventricles, and ventricles will start contracting. So that's why this is called as the ventricular depolarization. Ventricular depolarization. It is this point when the atria would be relaxing, but that signal is merged into the ventricular depolarization, so we will be able to see it separately. And then when these ventricles, they would be relaxing, so then the T wave. It is this T wave which would be called as the ventricular repolarization. So that's how this cycle, it keeps on getting repeated, right? One after the another. So any query this point, till this point, anything you want to ask? Just have a look at this image. This is a display of actually all the leads. So right now we'll be dealing with these leads. 1, 2, 3. And then we'll also be talking about EV, EVR, EVL, EVF. This V1, V2, V3, V4, V5, V6, we won't be touching them initially. We won't be touching them, all this. But you got the whole complete picture that this is how things are. Markups. First, talk about the limb. Please repeat fourth point. Fourth point was which one? Over here. Is it over here? Okay. This ventricular, when signals are passing through bundle of his, so I'm writing it through bundle of his. So you get this diffraction. Right? When the bundle of his is there, so you get this diffraction. And then see again the time is filled up, and then these ventricles, they are filled up, and then they contract, and the blood is pushed. So all we need to understand is this is atrial depolarization, this is ventricular depolarization, and this is atrial repolarization. And when it is going back to the original state. So let's watch this. Right arm, left leg. Now in real ECG, you'll find that there is a lead for right leg also. There is a wire for right leg. That right leg wire inside, there is no connection. It is just put so that no one makes a mistake. And this leg lead, it is connected onto the opposite side. When it is clearly written that this is for right and this is for left, then there won't be any mistake. So first thing first, that in case of ECG, as we said, let us say very simple classification. ECG leads, we are dividing into two parts. One where we'll be applying all those electrodes on the hands and the legs. That is, in other words, limbs. So they are called as the limb leads. Now they are again of two types. One, what is called as the bipolar, and second is called as the unipolar. Right? So this is bipolar and unipolar. Pole means two. That means there is one plus and one minus. Right? So there are two poles. There is one plus pole, and then there is one minus pole. So they all are called as the lead 1, lead 2, lead 3, where there is one plus and one minus. Let's see it here. It is. This is lead 1. Lead 1. So we have plus over here and minus over here. Right. So here we have applied electrodes on both the hands, but it is the left arm, right? It is the left arm's electrode that is positive, and right arm electrode that is negative. Okay. There comes the second one, where this was arranged like this. The second one, this is the lead 2. Lead 2 is between, this is the right arm and the left foot. Right arm in the left foot. Foot is positive. Right arm is negative. Simply speaking, right arm is always negative. Right arm is always negative, and left foot is always positive in any of the lead. I'll still explain. And this is the third one. It is the lead 3. When the arm is minus, that means the left arm is minus, and this right foot, that is plus. So what if I superimpose all three? if I draw it like this, so here is the right arm, here is the left arm, here is the here is the left foot. This one is plus, this one is minus. This is minus, this one is plus. Left foot is always plus, this one is minus. This much is okay. This would be lead 1. Right? This would be lead 2. This would be lead 3. All good? Okay. So we said that left foot is always plus. Yes, it is always plus. Perfect. Right arm is always negative. So here it is always negative. Here it is always negative. This triangle which we formed, right, where all things are, it is called as the Einthoven's triangle. It is called as Einthoven's triangle. So there was lead 1, lead 2, lead 3, which is leading to the formation of Einthoven's triangle. The next type of leads, you see there are limb leads and there would be the chest leads. Chest leads will be touching at last. Bipolars were 1, 2, 3. So then what about the other ones? Now these are unipolar. That means there would be only one positive. There would be only one positive. Rest of the entire circuit is made negative. I'll show you. So there is only one unipolar, that is only one pole. So which 3 poles? Well, right arm, left arm, and the left foot, right? So it is the right arm, left arm, and the left foot. Only these 3 are there. But when you try to do this, the signal drops. Signal becomes so weak because what you are doing is, these are the 3 poles. This is bit of physics and bit of electronics. From here you are sensing or you are recording. So what if you make both of them minus? So whatever the signal which is coming from here, it is received by the electrode. But when you try to do, now see it in Einthoven's triangle. I'll not mess with that. I'll draw it. Let's say this is Einthoven's triangle. So how simple was it in Einthoven's triangle? Plus, plus. Right. This one is minus, plus, and this one is minus, minus. Is it right? One, two. What did I say? This is right R for reverse. Correct? So this will be always minus. Foot was always plus. So if this is minus, this becomes plus, and this is, so this is how it goes. Left foot, left foot, always plus. Good. But now in cases of that unipolar lead, what if you make both of them, right, this and this negative, and you keep this positive, and then you record the signal. When it comes to, say, this portion that is left arm, so you make these two neutral, negative, and then record from here. Getting it? So the point is, rest of the leads, they are made neutral, right? And then you are recording from one end. So this is done electronically, right? There is, because there are only 3 connections, and from 3 connections you are generating 6 different leads. 6 different, as if these are the 6 cameras which will be watching the heart from various angles. So that's how it really goes. These are called as the VR, VL, VF. This is for right, this is for left, this is for foot. But because the voltages are very less, that's why electronically they are enhanced. So otherwise the signal, the ECG would come like this. You won't be able to even see it properly. So that's why they are A. A stands for augmented. So they are the augmented leads, right? And they are collectively called as AVR, AVL, AVF, and that's how they are used. The rest of the story is very simple, and it is, these are called as the chest leads. Chest leads. And these chest leads, they will be going all the way from V1 to V6. So V1, V2, V3, V4, V5, and the V6. Again, these are the chest leads, these are unipolar. We have V1 to V6. Unipolar. So here, the unipolar, they were right arm, right leg, so we call them AVR, AVL, AVF. So these are the 12 leads. Now we come back to our one concept. That's the heart. Right? So that's the heart. Oh, this is the heart. Right arm, left arm, lead 1 we have drawn. This is minus, this is plus. Right? This is minus, this is plus. So now what are you doing? You are watching the heart from left side. Because what you'll be watching, you'll be, here is the eye. Here is the eye. You are watching it, that signals are coming towards me, but they are going away from me. If the signal is going towards this electrode, then it would be up, correct? And when it will be going away, so it will be going down. So the point is, you are watching the heart in lead 1 from the left side. Is this part clear? Yes, no. Yes. Okay. So when I draw lead 2, so from where I am watching the heart, or which part of the heart I am watching, from whatever we discussed till this point. Right side. Okay. I'll not say anything like you are right or wrong. Just give your opinion. That's fine. Right? Okay. So you said that we are watching from this side, right side. All right. right? Okay, Unnati is telling from below. Okay, from below. And there was one more answer, and that is from the left side. Yeah, sure, from the left side. Okay, watching from, okay, from, all right. Let's settle it. This is lead 2. Lead 2 is, this is minus, this is plus. As soon as say this is plus, we are watching from below. Simple. We are watching from below, right? Not from right, because this is negative. Right? So that's why this is from left side. For left side, so we have got wonderful lead 1, right? Absolutely watching from the side. This is going towards below this particular electrode. So it is just recording that is anything coming to me, right? So it will watch the lower part, this base of the heart. It will watch as if it is watching from there. See, if there is any tissue which is damaged over here, then signals are going like this, right? So over here, we won't be getting, मतलब जहाँ plus वहीं से will watch. Absolutely, बिल्कुल बिंदास. You can remember it exactly like this, right? So the signal will be going like this. So यहाँ का signal affect होगा, right? 1. But will this 2 be affected? No, 2 is going in this direction. 2 will be affected when there is basal diaphragmatic infarct. तो फिर वो रास्ते में आया है problem. Right? So yes, very rightly, you can see it like that whenever there is minus, that is beginning, and wherever there is plus, that is the point from where you watch. Right? And when we say lead 3, so here also you will be watching from below. Correct now? You will be watching from below because this is minus, this one is plus, foot is plus. So you will be watching from below. This is the representation. So now if we really add into it, so can we add that when it is lead 1, so you are watching it from the lateral side of the heart. Right? Everywhere it is of the heart. So that is lead 1. When it is lead 2 and lead 3, so it is from below. That was not complicated, right? Quite easy. And when you, what you said is, wherever there is plus, that is the point from where you watch. Bindas bilkul 100%. Right? You are very, very right. This is correct. And this one. All set. So now we know about lead 1 properly. We know about lead 2 properly. And we know about lead 3. If this is set, we go for now the not very difficult, but this is the portion which requires bit of your attention. But once you have understood, finish. All set. The most powerful system of the ECG learning is what is called as the Kabera system. Right? It's called as Kabera. But I'm taking you to that Kabera. Over here, 1, 2, and 3. We drew the triangle like this. The triangle whose all the angles are same, right? If all 3 of these angles, they are same, so then what would be the angle? The sum total of all the angles of triangle is 60. Okay, this is 60, right? Sum total is 180, right? So this is because they all are same, so 60, 60, 60. Done. Okay. So now, see, this is 0 degree. This much is 60. Another 60 you travel. This. So if I temporarily remove all rest, right? Let's say I remove this, I remove this, and I remove this. So can we? So can we have just these three? This is 1. This is 2. And this one is 3. They are 60 degrees up. 60, 60. Right? This is 60. This is another 60. Right? So that is 1, 2, and 3. And these are the angles. Okay. Now I remove this. You know about the vector? Vector. Heard of it? Vector. Now we'll be using a digital vector, because this thing will give you that understanding to pinpoint, locate the pathology pinpointed. So vector is what? What is vector? If I pull, here is a ball. If I pull it from this side and someone is pulling it from opposite side, so this is A and this is B. Right? One object, it is pulled from this side, and same object at the same time it's pulled above. Where will this object go? It will go this side and it will go this side. It will go towards the side of A or to go towards the side of B. Diagonally, very true. It will go like this. Correct. In between. Yeah, exactly. It will go over there. This is vector. Vector is summation of both the forces. Right? Summation of both the forces will lead to the direction which will be in between both of them. Very fine. I'll say honestly, in the initial days when I was trying to understand this, right, I couldn't really find out that why these angles, minus 30, 90, 150, why? Right? You understood it really very fast. See, what was AVF? What was AVF? AVF was, right, all you need to do is draw this. Right? We have got right arm, we have got left arm, we have got left foot. The whole thing is, say, 360 degrees. And here is our object. So when we are making this thing, when we are making both of them 0, it will be pulled over here. And if I really want to distribute the entire 360 degree into 3 parts, so what would be the angle between all 3 of them? Because see, right, this is like a circle. This is like a circle. It reminds me of Independence Day movie, Independence Day. When they said, that's what they said. When Independence Day, they said that it is just 3 stations which are needed into the geostationary orbit, so that they can really communicate with each one and they can put their footprint on any area of the earth. So yes, very right. That 360 degree. So over here we have got 3. So this is 1, this is 2, this is 3, total 360 degrees. So that's right, all of you. Right? This is the gap of 120 degrees. Gap of 120 degrees. We superimpose now both these things. We superimpose this along with the nth one was lead 1, lead 2, lead 3. So here it is. We'll keep on taking this 0 degree. That's right, because that's where we start. Right? This whole thing is 360. Then comes this lead 2. Lead 2 is at 60 degrees. Makes perfect sense. Correct. AVF, that is absolutely down, straight. So this will be our reference. This will be our reference. This is absolutely down, right? Absolutely down. Foot is down, right? Foot is not at an angle. Foot is absolutely down. So this is 90 degree, right? 90 degree. So that is fine. It is 90 degree. So that is also fine. Then comes our other lead 3. Lead 3 is also 120 degrees. So this is also good. Life is fine. Only thing to calculate. We are over here. We are over here. From 90 degree, right? If we have to move another 120 degree, right? We have to move 120 degree. So how much will we go? 90 degree all the way to 100. Add 120 degree. So we'll add 90 plus 120. So the total comes to 210 degree. Right? So here it should be 210 degree. Why this is minus 150? Minus 150 is this is 0, and then we call this thing 180, right? 180. But then this is 0 now. Negative, exactly, perfect. So this area, right? So you have understood it. Very nice. This area is a positive area, and this area would be a negative area. This area would be a negative area. So this means this would be important when we see that whenever there is cardiac enlargement, right-sided or left-sided, so these axes will move towards positive or this axis will move towards negative, right? So wherever the muscle tissue will become bigger, more current will come. So the axis will rotate. Wherever there is infarction, right? The signals are not coming. So then the opposite side, the signals will start going. So the point is, this is 180. From 180, it will start going towards 0. So it will be minus. It will be minus. It will decrease. Right? So thus, we have to travel 210 degrees from this point all the way to this point. Right? So 90 to 90, this much distance. Right? This we have covered. Right? Because from here, our purpose is to go till 210. So 180 reached, and then we have to travel another 30 degree. Correct? Another 30 degree. So this is 180. So then there would be, so from here it will start going minus. So 179, 178, and minus 30 reduce. So it become minus 150. So if you consider all the way from 0 all the way over here, this is true, this is 210 degree, but it will be in the negative zone, it will be minus 150. Okay, I didn't understand about cardiac enlargement shifting points. That was just an example. It will come. Right? It will come. Right now, focus on this. I told you that yes, what you are learning, this is important for that diagnosis. Right? So, and I haven't even explained it more. So I just said one thing. Okay, don't be confused. I just said one thing. If the muscle is more, so then there would be more current. If the muscles are less, there will be less current. Correct? If the muscles are more, right? So from here, the electrode will say, big current. If the muscles are less, it will say, okay, that's the difference. So when in case of cardiac enlargement, right, left ventricular hypertrophy, left ventricle as such is a big muscle, right? When there is hypertrophy, the muscle becomes big. Yes, you will be watching the ECGs like this, big spikes, right? Big spikes, right? So that's the thing. That's the thing. But right, so quite easy. This will understand when we'll be talking about the abnormal ECGs, right? Tomorrow means next time. We'll first understand what can go wrong, and then we'll start watching diseases one after the other. Right? So many diseases. even you'll be able to understand that what would be the changes into ECG when there is increase or the decrease calcium, potassium. Yes, you'll be able to see that from ECG. So many diseases. You'll be very happy that ECG is like a language. Heart is telling you, mujhe ye hua hai. But these angles at that point, right, we won't be able to go back to these angles. It has to come like a fraction of second. That we are talking about AVL. Yes, we are watching the heart from an above angle, -30. So if the heart has shifted to that angle, yes, that would be the strongest signal, right? Because we'll keep on doing the reverse engineering. When we'll be watching that big spikes are coming over here, so that means AVL is watching a big spike, right? So that means heart, it is the signals, they are coming from over here. Why signals should come over here? Because heart has enlarged and it has become this big, right? So this area has become big. This area is what? Lateral side area is left ventricle. So that's how. So that's how we'll be able to diagnose. Acha, chalo. First, let's finish this. So this is clear why this is -150. Why this is -150. Any doubt in this? Because yes, you have to remember. Yes, you have to remember all these numbers. Right? We'll simplify at the end. You have to just watch that one image, draw it 3-4 times. It would be cemented into the brain. Last page, it would be like summary of everything whatsoever we have discussed today. But this 150 should be clear. Not that complicated. And then from -150, 151, हाँ कोई बात नहीं, बोलो ना, we'll discuss it again. I don't want एक भी जना doubt के साथ नहीं जाए. Even if it is, I don't mind, I'll explain 10 times. But सीख के जाना. यहाँ तक पता चला AVF is 90 because foot बिल्कुल 90 degree, foot is straight. ठीक. Everything is at, forget about this. 0, 90, 180, 270. This is fine. So if this is 90, this is 90. This is 90. We have to draw 3 axes which are at the distance of 120. Where will be the next axis? This is A, right? इसको नाम दिया A. B will be at what angle? 210. So 210. This is B. Where will be C? C. 330. Next, this is 180, this is 0. So if I want 0 to 180, and then from 180, I want to take it back to 0. So here for every angle, how shall I start writing? 179, 178, correct? So that it goes back to 0. 2. Or can we really do it something like this? That because we want to go back, right? Want to go back. So it is into the negative portion. So when we travel from here to here, what would the number be? It is decreasing, right? So if it is over here, just 1 degree, 1 degree hota, so we would have written 179. Right? We would have written 179 na? Because we want to go back to 0. So then uske baad 1 hota to 178. So that way we keep on decreasing it. So 10 kam kiye to we reach to 170. Or 10 kam kiye to we reach to 160. And 30 is what we have to reduce. So then this number would be what? This number 210 wala. That would be 150. Correct? Ha. I was waiting for your answer. That would be 150. But yahan pe bhi 150. And what angle would this be? This would also be 150. This is 90, then there would be 120, then this would be 150. This is also 150, this is also 150, this also 150, this also 150. Confusion. But because this we are going into the positive direction, 0 to 180, and in that from 180 we are going back to 0, so that's why we start putting it minus. Plus, right? We put it minus. So now there is no confusion. When we say the angle is plus 150, that means we are into this lower portion. When it is minus, so that means we are talking about the upper portion. There would be very few diseases in which things will be going into that negative area, right? Very few diseases in where the heart axis will be going into that negative. बहुत rare. Mostly it will be between positive. But in certain cases, when it goes into negative, then the ECG looks scary. Right? At the end, after that, right, after we'll discuss all those normal, I'll start showing you even those ECGs. And then just let me know if you are ready. Once you have understood the entire ECG, right, we'll do that. Straight away, we go for the test only on ECG. Only on ECG. 30, 40 ECGs. And I'll give you enough time. Right? We can take even 20 ECGs. So at this level, if even these ECG आपने diagnose कर लिया, तो boss, that is superlative. Superlative. Right? Out of those 20 ECGs, right, this is just a random number, right? Out of the 20 ECGs, 5 ECG, they will be like myocardial infarction. मतलब वो तो आना ही चाहिए. You should know. 2-3 ECGs, I might put some variations. 2-3 ECGs conceptual. हाँ, 2 या 3 ECG ऐसे होंगे which will be very tricky. Tricky means if you follow the sequence, you will be able to diagnose. But yes, from that point onwards, right, there would be like a transformation. And you will feel that हाँ, medical science is such an amazing thing. I'm really sorry, मैंने कितने लोगों के आंसर नहीं किए. When you have asked that instead of medical science, can I take physio and dental, वगैरह वगैरह, Ayurveda, etc. So many questions. I have written you, hang on. Right? There will be 2 or 3 lectures, maximum 3 lectures on ECG as of the 2. Right? And then we'll have a test. But that's the day when you will feel the transformation. Same thing, I really want to do it in the form of auscultation. Right? Auscultation also. So, can we plan? Because if we have to plan, right, I'll start. I got several ECGs, so I'll start sorting them out. Done. I think there were not much, 3 years I have come. We are over almost 88, 90. Let's take it general. किसी को problem नहीं है ना? We go for test. We take it for granted. We are keeping the test. Shabash. Happy. मतलब यशस्वी, मतलब प्रॉब्लम नहीं है उसका नो लिखा ना. Next, third angle would be from 210 that travel to 120. We travel to 120. So what would be the new distance? That it would be 230. Mala, it would be 330. So this 330 is how much? 330 is how much minus? I got it. Huh? So this 330 is how much negative? Negative which number? That's right. Why only one answer? This is कौन सा number? 2, 3, 6. This is minus 30. Correct. Minus 30. negative 30. Now see how easy this is. This is what we have, right? So this is 0, right? Then this is 2, this is 60 degrees, then this is 320 degrees. Settled. AVF, start the journey with 90. It will move on to minus 150, that is the AVR, and this is the AVL, that is another minus 30. Set. Right? So a neat figure is this. Everything clear? Huh. I'll draw 2-3 times. As such, why I'm telling you draw, so that when you draw, when you write, it becomes more and more clear. So this is all good. So you have learned Einthoven's triangle, right? You have learned the AVR, AVL, and AVF. All good. The next thing which you have to learn is, that is when you are watching the heart from at an angle, right? You are watching the heart from an angle. Which plane are you watching? So we have x-axis, y-axis, and the axis which is coming out from me and going towards you, the z-axis. Okay. So that's how we say, right? This is the y-axis, this is the x-axis, and this one is the z-axis or z-axis, which is indication of depth. Heart is a 3D structure, so we have to watch the heart from every angle. So that's why these are the various angles. But when we are talking about, say, the right arm and the left arm, this is one plane. Right arm and left foot, that is again one plane. But it is not telling the posterior or the anterior part. That's why there comes the chest leads. So where we are watching the heart from the front. So in all these things, if I write it like this, the lateral part, lateral means the left, right, from the left side. Which were the leads which were showing as if we are watching from the left side? So those were over here. Over here, it was AVL, correct? It was watching from the left side. It was the lead 1 which was watching from the left side, correct? Am I right? Right. This is what is happening. See, AVL is where? AVL, here it is. Let's write it here. AVL. So we are watching from the left side. What about this? We are watching from the below. So from diaphragmatic side. And this from right side. And same principle holds true. Plus side is what is watching. So this is plus. Why this is AVL is plus? Because all of them, AVR and AVF, they are made neutral. Right. So this is plus. This is plus. Similarly, this is plus. This one is plus. This is AVF is plus, because others are made neutral, augmented lead. And this AVR is plus, because AVL and AVF, they are augmented to minus, to neutral. So that's how you see. This is the crux of the entire thing. This part is clear, this image. So when I show you ECG, that it should be crystal clear that what we are talking about. Any doubt in this much? If this thing is understood, almost 90% through. AVR should be negative. AVR is not negative. See, AVR, it is R for reverse. What I say is, because see the signals, this is ASA node, this would be AV node. All the signals, they will be going like this. So for AVR, so everything is going away from it, right? Everything is going away from it. That's why the ECG which will be formed, it would be totally reverse ECG, pura ulta. But why? Because our electrode is positive. It is watching from there. Signals are going away, right? But when we, technically speaking, AVR is what? Augmented vector lead on the right arm. So augmented vectors, they are made how? Augmented vectors are made. That is when this signal, and when the AVR is sensing, it is a sensor signal over here with AVL and AVF made neutral. Correct? So it will be positive. You got it? Exactly. So this thing is clear. And as you will start watching the ECG now, it will be like, there will be aha moment. To get the proper ECG, we make AVR negative. We don't have to make AVR negative. My dear, AVR would automatically be negative nahi ban raha. AVR will be receiving the signals, because in AVR, signals are going from the AVR perspective. Here is SA node, here is AV node, right? See the signals, they are going, sabhi duri bhag rahe, everyone is going away. So that's why AVR will be making the ECG pattern with reverse of AVL, because with reverse of one, say in one, signals are coming, right? For two, signals are coming. So let's take the example of two signals, SA node coming, AV node coming, right? All positive, yes, every signal is coming. But when it comes to AVR, everyone is going. So that's why it will be just the reverse of what is seen by two. But our electronically speaking, so it is positive. No? Positive means this is the eye. This is the eye. We are watching it from here, our eye. That positive, someone wrote very clearly, right? This is the positive, means we are watching it from that side. Precisely, the side from which we are watching will always be positive. 100%. So thus you can say that this positive one is our eye. But this eye, Vichari, right, is crying, yeah, everyone is going away. Right, everyone is going away. So that's why it will be making the reverse ECG. Right, reverse ECG. The entire ECGs will be completely inverse. Right. So that's why this we keep in mind. But that doesn't mean that AVR is a negative electrode. AVR is a positive electrode, because positive only can sense the signal. Right? Because in augmented, A stands for augmented. Otherwise, the signals are so weak. So that's why they are made neutral, right? They are made neutral. So that's how things really go. Right? I hope I am clear. Right? How to make the proper ECG? We'll be learning the calibration system. Right? How to do calibration. So when you do the calibration, ECGs will be marvelous. Absolutely fine. Okay. And importance of calibration, I'll show you one relative's ECG. Such a ECG was taken in such a poor way, with such weak signals, that it was about to, a major condition was about to get missed. गाली बोली थी, बोली नहीं थी, निकल गई. I didn't understand why the signals will go away when it is taken as positive. Okay, tell me one thing. Say That's a railway track, a railway platform. Let's take it platform. So this platform, and let's say I'm standing here. You are standing there. A train is coming, right? Railway engine, only the railway engine, and that purana chuk 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 wala engine, right? This is the door, right? So when I perceive, so it is like engine is coming, right? And then after one point, what would happen? As it will cross this, what would happen? I'll see that this is going, right? It is going. So if the signal is, if the engine is coming, so then I'll say yes, coming. And then I'll say it is going. So it is going. Right? So I'll be making a pattern like this, where this is A, and when it is going, then this is B. So far clear? So far this much is clear. How will you make the pattern? For you to, it is coming, right? It is not going at all, it is coming, right? So in that case, your signal would be, that's it. That's it. This would be, engine has stopped at this point. So you will be telling that, yes, the graph is like this, right? I'll say, no, the graph is like this. Who is right? Both are right, because we are watching from different angles. And what if, for some reason, it happened like I came a bit late. So when I reached the angle, the signal was over here, so I missed that. So I'll be drawing the signal only like this, that it is going only. Because when I'll watch that, yes, this railway engine is going, right? So I'll keep on dipping it minus. While for your perspective, it is coming. So it would be positive. See, it would be completely reverse. Definitely, the amount of muscles affect signals, definitely. That's what we said, that when we'll be watching the left ventricular hypertrophy, you will find that this is the normal QRS complex. The QRS complex will skyrocket. They'll be so big that they will be overlapping. That will be the thing. Because this is what the question you asked is, that the amount of muscle affect signals 100%. It is the amount of muscle only which we want to evaluate. So that's the reason we'll be able to understand cardiomegaly, we'll be able to understand there is increase or decrease in the heart size, we'll be able to understand the rotation, we'll be able to understand is there some area where there is improper conduction, is that conduction related to atria, is it related to ventricles, all the things, more than 50 diagnoses. Yes, it will change the diagnosis, absolutely, fully change the diagnosis. So we'll be learning it in every way, that what is the speed, what is the regularity, right? Is the SA node constantly firing? Then it is a regular. If the SA node is not firing properly, 2-3 fires, and then it is taking a gap, and then the AV node comes in. So in which there is atrioventricular dissociation. They both are beating at their own rhythm. Yes, we see the ECG, and within 5 seconds we'll be able to tell that. Right now, it might look like a jadoo. So many things, yes, but when you will be going for, I have designed a system, just a 6-step system. Any ECG comes, you just follow that 6 step. And when we'll be discussing the ECGs, we'll be following all the 6 steps in that order. Even if it is so obvious that this is nothing but septal infarction, no, we'll not be standing like that. We'll be going step 1, step 2, step 3, step 4, step 5, step 6. First, so that in your brain, it is set that every time you see the ECG, follow that pattern. When you follow that pattern, you'll be able to diagnose even a complex conditions. So this is clear, right? So AVR is a positive node, positive electrode, positive in the sense it is the eye. We are watching it from there. The P wave is for SC node and P wave, the P wave, we said it is the atrial depolarization. Okay? Atrial depolarization. That means there is that right? It is this part in atria. So this is the P wave. So that means in case of P wave, when the P wave comes, this means the current has started going towards the atria, right? In the atrial muscles, they are now conducting. They are into this phase. And now the contraction would occur. So then they contract. And that's the reason this is the P wave and this is the filling phase. This is the filling phase. Because now the atria, they are contracting. Their depolarization phase is over. Right? They have reached, and then their contraction starts. When their contraction starts, that's why we have to give time so the ventricles fill. Right? Straight line is for AV node. Straight line will not say it for AV node. Straight line is a delay. AV has not yet fired. Because if AV fires, so then from AV to straight away, yeah, it is for delay. Exactly. So you can, right? We talked about it. Delay, or it is for the ventricular filling, you can see. Ventricular filling. Because that's the phase. At this point, the atrias, they contract. When they are contracting, the valves are open, then yes, it is the blood is going into the ventricles. So that's why ventricles are filling, and that you can also say delay. AV is not firing. AV is telling ventricles, you just get filled up, and once they are filled up, and then it sends the signals to those bundle of phase, and then Purkinje fibers, and then they contract. Right? This is clear now. The question which you have asked, right? Because I haven't seen your reply. That has to be clear. Okay. Now the last figure. This is the figure which I really want that all of you, right? That's like, normally I don't give homework, but this is the homework. This is a homework. This is called as the Kabira system. This you have to draw so many times till even randomly, if I ask that, okay, what is present at 60 degrees, and without any confusion, you should say that it is lead 2. It should really go to that level. Because it will be very helpful for the diagnosis. Because we'll be able to see all the rotations. If I say, okay, at what angle the AVL, or if I ask in a reverse way, that at plus 150, what would be that? Immediately, yes, plus 150, yes, so that is the opposite side of AVL. Right? Let's see this. First, we see what we have already discussed. This we have discussed, 0. This we have discussed, 2. This we have discussed. We are all taking only the positive ones. So these up arrows, they are positive. Up arrows, not positive. Up arrows, they are positive. Now, the negative of it. If this is 0, so then this is the positive end, so this is the negative end. So that negative end is at minus 180 or plus 180. Basically, it is one and the same thing, right? So this is 180. So this is lead 1. This would be the negative end of the lead 1, correct? Similarly, over here, this is lead 2. So the negative end of the lead 2, negative end, that is 180 degree turn, right? So this is 160. So this is all the way to over here. Right? So it would be 160 minus 180. So that will be minus 120. So this will be the opposite one. See, all of them, their total would be 180. Total would be 180. So because that's a gap, no? That's a gap, the total. So this is lead 2, right? But it is on the minus side. Delay after T wave is we'll see that. So this is done. This is done. This is done. This is 120. When it is 120, the yes, opposite side has to be minus 60, right? Because so the total is this. So this is also done. Plus, if you have understood this much, then rest is a piece of cake. This is plus 90. So then opposite would be minus 90. Right? Very easy. Similarly, if this is plus 150, that would be minus for the 30. The total has to be 180. This is 30 plus 30, so then opposite would be minus 150. But the difference is, this is positive, correct? AVR, because we are watching it from here. So that's why see the up arrow. See the up arrow, right? Up arrow. But don't make mistake in this. AVR, right? In AVR, we are watching from the right side. And this one, this is the down arrow, it is minus. The rest all are self-explanatory. Right? This entire system is called as the Kabera system. Kabera system is the most authentic way to learn the ECG. Now for the chest. They are, for the chest, the leads which are noticed, they are all V1, V2, V3, V4, and it goes towards the axilla all the way. So those are those leads, right? 1, 2, 3, 4, 5, 6, all the way it goes back, right? So you are watching, and these are all positive. These are all positive. So that means you are watching from the front, right? So as if you are just taking a camera, and then you are taking the heart all the way. So you are watching the surfaces. So it means that if there is right ventricular enlargement, right? Imagine a right ventricular enlargement. So which of the chest lead will be showing us big waves? Right ventricular, very nice. Good one. Right ventricular enlargement. Yes, Saksha. Then which chest leads? My friend, V3 to V6. V3 to V6, right? V6, the heart is like this. Right ventricle is in front. This area, that would be the left ventricle. You got that thing? So if you say V1, V2, V3, then they are right? Because you are watching the front surface. V4, V3, V4, V5, V6, so then it is like you are going on the side, right? That is the side when there is left ventricle. Okay, you got it? Because there are just four replies only. Is this point clear? You are watching the heart from the z-axis. Right. Okay. Right. Great. नहीं समझा? This is heart. Sure. This is heart, right? Which chamber is this? Which chamber is this? Which chamber is this? So this one. So this is right atrium. This one is right ventricle, and this one is left ventricle. Left atrium is behind, right? So out. Right ventricle. This right ventricle, the leads which are kept in front, so they will be watching it, correct? because right ventricle is in front. So if the lead is kept over here, so they'll be straight away watching. So that's why V1, V2, they will be watching the right ventricle. So if the right ventricle is enlarged, the maximum effect, the maximum signal will go to this V1, V2. Right? So they will be big. When the left ventricle is enlarged, so we have got V3, then comes the V4, then comes the V5, then comes the V6. So even these leads, they will be affected. Because when the left ventricle is enlarged, so then the leads which are on the side, right, they will be watching it. So that is how they will be enlarged. Right? So simple, the lead which is near to that surface, that will be representing the enlargement of that particular chamber. Correct? So standard figure, right? This is the right atrium, this is the right ventricle, this is the left ventricle, and this is the left atrium. All these leads, they are arranged, right? They are arranged like this. This is the V1, this is the V2, this is the V3, this is the V4, this is V5, this is V6. So as if we are watching from the top, right? So this is V1, V2, V3, V4, V5, and V6. So thus V1, V2, V3, right? They will be able to see the right ventricle. V4, V5, V6, they will be able to see the left ventricle more clearly. Correct? Because signals, when it is enlarged, strong signals will be coming like this. When left ventricle is enlarged, strong signals, they will be going towards like this. Clear? So thus, this would be the game. This would be the game of all the leads. That's how. And when we'll see the ECG, there is a pattern. There is a pattern that we'll be getting it like this. It will always be in this order. Right? Lead 1, lead 2, lead 3. Normally it is written lead 1, lead 2, lead 3. But when the ECG is taken in emergency, then it is missed. Right? So it is taken for granted that you know which lead is what, because it is always arranged in this order. AVR, AVL, AVF, and then V1, V2, V3, V4, V5, V6. It is always, this is an international standard. It has to be in this format. And now that the digital have come up, they are automatically arranged like this. So when you get a piece of that ECG, if it is a running strip, then it will be a long ECG. Right? So that is where you have to fold it and you have to check it. We'll see all the types of ECGs. I think what is called as a running long strip. We'll see that also. Right? But this is a pattern. This is how it is recorded on the ECG output. So that's how it goes. If it's negative 60, will we call it negative lead 2? Or negative lead 2, you can call it. You can call it negative lead 2. In fact, it is, we can say it like, you can say it like that this is, you're telling about negative 60, means you're talking about this or you're talking about this? I'm confused. Means if you're, see, this is lead 2, correct? This is lead 2. So normal lead 2 is plus 60. Negative end of the lead 2, that would be minus 120. So you mean to say this or you mean to say this? Got it? Fine. Good. All right. So that's it for today. Thanks a lot. And do revise today's session very properly. Normal leads of the heart, they are always like this, but all these angles plus minus, right, they will be important from the diagnostic point of view. So next time it will be still more clear. But just if you forget everything, it is fine. Remember this much, more than enough. All right. So thanks a lot and take care. But I was about to say, wish you a very happy weekend. Week to shuru. Okay, take care.